Hi, good evening, everyone. I can see people logging in. Hello, Praveen sir. What you're doing here? So, guys, we'll wait for a minute or so. Let us wait for other people to join in, and then we'll start with this discussion. Just let me know if my voice is clear. Please just in the comment box, just let me know if my voice and the video and audio and video both are clear, so that we can just start up with this. We'll just see after this. Hello, Dr. Renu. Hello, Raj. Okay, thank you, Dr. Renu. Yeah. Chalo, guys, without a further ado, I guess we should get started. Well, for those who don't know, myself, Dr. Ashwani Kumar, I'm a faculty of human anatomy here, and today we are conducting this live session to discuss the histology of the lymphoid system. Lymphoid system, needless to say, guys, out of the histology part, one of the very important from the histology perspective. General histology has always been important, more than the systemic one. In the histology part I'm talking about, and the cartilages, the types of gland. You recently got a question on the types of gland and the lymphoid system histology. These are like the top-notch topic and very frequently asked. This is our first session in this way using the OBS on the Facebook. We have done it on the YouTube and on your app also. So it's a kind of an experiment for me as well. So if it goes well, then we'll be conducting other live sessions also for the histology. So that's how my plan is to cover up the entire histology through these live sessions. I know many of you must have attended the class till late 9:30. I don't probably, or many of your medicine classes also going on. So if you're tired, if you can't attend this class or anything like that, just please skip it and just take rest, because anyways we're gonna record this class and keep it in the Facebook also, and we'll post it in the YouTube of the DBMCI. So nothing to worry about. I mean, if you're tired, just have your dinner and just go off to sleep, no problem. I guess we have enough crowd to start with. I probably will not be able to take a doubt in between, because that will be occluding my screen, the one which I'm using to write on. So that's why I'll be swiping the comments to one side, and then I'm gonna get started. I already got a feedback from you that the sound and everything is correct. So yeah, let's get started. Okay. So guys, the plan is to discuss the histology of the lymphoid system. I'm pretty sure that this is one topic. I had a word with Dr. Praveen also a few days back when we are planning to make an integrated histology and pathology combination recording for this topic of lymphoid for the histo and the histopath itself. So we might be doing it a bit later, but as of now I'll be today talking about the basics of this lymphoid system histology. So let's get started. And second thing, because I'm going to show you some the real-time sections and slides here. If you want to take a snapshot, you're most welcome. Otherwise, whatever I'm writing and labeling here, I will give you the PDF file. What I'm going to do is, after the video get over, I'll just take 10 minutes to take the snapshot of all the slides, and we'll make a PDF, which is like it will take 2 minutes only, and we'll post that in your group also, so that you don't have to bother about that, where we'll get these soft copies from. So guys, to start with, well, when we talk about the classification of the lymphoid system or the lymphoid tissue, we talk about the two type of lymphoid tissue. One, we have a diffused lymphoid tissue. And when you say diffused lymphoid tissue, it is basically the random aggregation of the lymphocytes that you see present usually in the lamina propria. In the lamina propria, whether it's the lamina propria of the GIT we are talking about, or the respiratory tract, whatever. So just a random aggregation of some lymphocytes present in the lamina propria of the GIT or respiratory tissue, that is called as a diffused lymphoid tissue. And then we have the dense lymphoid tissue, and this dense lymphoid tissue could be of two types. I mean, you can broadly divide this dense lymphoid tissue in two types. We have this called as, one is called as a MALT, which is mucosal associated lymphoid tissue. Mucosal associated lymphoid tissue which can be of further many type, like GAL, the gut associated lymphoid tissue. It can be RAL, the respiratory associated lymphoid tissue, or you can the pulmonary associated lymphoid tissue also. So where you have these pairs, patches or solitary nodules which are present in the lamina propria of maybe in the respiratory tract, maybe in the GIT. So those are called as a mucosal associated lymphoid tissue. As you can see some examples in there, like the solitary nodules can be seen. The pairs patches which you all know are present in the ileum, those pairs patches is an example of the MALT only. The lymphatic nodule present in the vermiform appendix, and even the Walder's lymphoid ring. You all know about the Walder's lymphatic ring, inner and outer. They are also the example of the mucosal associated lymphoid tissue. But mainly for the topic that we're going to discuss today, we'll be talking about this DEO, that is discrete encapsulated organs. In the dense lymphoid tissue, we have these discrete encapsulated organs, and we will be talking about these dense encapsulated organ, which is a complete unit by itself. Like we got a thymus, we got a lymph node, we got a spleen, and we got a tonsil. All the palatine tonsil, again, it's a part of a MALT only. It's a mucosal associated lymphoid tissue. So the basic purpose here would be to understand the main features of these four things: the thymus, lymph node, spleen, and tonsil, to understand the circulation, and also the main thing is to differentiate between these four slides if you get an image-based question on that. Okay, so let us start our discussion with the the first in the category. So we're going to start with the lymph node, guys. We're going to start with the lymph node first. Let's have a discussion first on the overall gross anatomy of a lymph node, how it looked like, so that we can have a better histological prospect of that. Now, as you can see here, this is a picture which is showing a section through the lymph node. Now, first of all, guys, broadly the lymph node can be divided into the cortex and the medulla. When you see the section, you can appreciate that inside it can be divided into the cortex and the medulla part. Now, the one which I'm highlighting here, this is the medullary region, that is a medulla part. And the one which is on the outer region, that here is the cortical region, the cortex. So the first thing is we divide into the cortex and medulla. The cortex can further be divided into the deep cortex, and we have a superficial cortex. If you just go with the labelings which I'm showing you, so we got a superficial cortex and the deep cortex. Deep cortex is also called as the paracortex. It is also referred as the paracortex. This deep cortex is also called as a paracortex. Usually the term uses a paracortex here. And as you can see, these arteries are coming in, all these the blood vessel coming in and going out. So this paracortical region, this paracortex region, which is in this region here, that is here, is the region where you have these high endothelial venules present in. I'll talk more about that. We have a high endothelial venules present predominantly in the paracortex part of the lymph node. Other important thing to note here that we are talking about the encapsulated structures, guys. So this is having a capsule around it. So we do have a capsule. So there is a thick, dense, regular connective tissue we have that is forming the capsule of the lymph node. And these capsule is sending in the trabeculae, it is sending the septation inside, and these septations are basically dividing the cortical part. So I'll keep showing you all these. That's a trabeculae here, the trabeculae. That is, trabeculae is nothing, it's a septation only, and the trabeculae extending inside and dividing the cortical region here. The important thing to note that deep to the capsule and deep to the trabeculae, can you see that space which is colored green only over? That space is called as a subcapsular or subtrabecular sinus. Now you can see this one I'm highlighting here for you. This is subcapsular. Look at this space which is present deep to this capsule, that is a subcapsular sinus. And the same subcapsular sinus is running along with the trabeculae. That is called as a subtrabecular sinus or paratrabecular sinus or simply trabecular sinus. They run with the septations here. Well, what is the point here? What is the concept? That when you look at the convex outer surface, this bean-shaped the lymphatic lymph node outer surface, the convex surface, you will see there are numerous afferent lymphatic vessels which are coming in. Now let me just mark it for you. Can you see that afferent lymphatic vessel, the one which I'm marking here? So like we have numerous lymphatic vessels, afferent lymphatic vessels which are entering to this convex surface. And they're obviously having valves, so there's no backflow of the lymph there. They are all having the valves. I can appreciate a valve also present there. Essentially, we have a valve close to the lymph node also. We have numerous valves inside, but we essentially have a valve close to the lymph node as well. So what you see, the lymph is actually coming through these afferent lymphatic vessels, and then it goes into this subcapsular sinus. Followed from the subcapsular sinus, it goes into the trabecular or paratrabecular or subtrabecular sinus. And then followed from there, it goes into the medullary sinus. So coming from the afferent lymphatic vessel, if I give it number 1 here, it goes into the subcapsular sinus, that is number 2. It goes into the trabecular sinus, number 3. Then it ultimately, the lymph goes into the medullary sinus, which is in the medullary region. We'll talk more about that. And from there, you can see these, they're converging into this, a single efferent lymphatic vessel, which is coming out, that is number 5 in there. That's how the lymph is flowing in the lymph node, starting from the numerous afferent lymphatic vessels on the convex surface, goes into subcapsular, the subtrabecular, medullary sinus, reaches to the hilar region, and from there we have a single efferent lymphatic vessels which is emerging out, also again having the valve in it. So we do have a valve in the afferent and efferent both lymphatic vessels. This is just an overall look how the lymph node will look like in a gross section here. Now let's get into the more of an histological aspect of this, guys. As we said, we can divide the slide into the cortex and the medullary part. Now if I show you in a low magnification, that's how the slide of a lymph node will look like. And I'm sure you can appreciate the same thing. It is showing you this, the cortex, or simply call it superficial cortex part here. Then we have a deep cortex, which is basically the paracortex region, the one which I'm highlighting here. This is the paracortex region, and the paracortex region that is followed by the medulla. And in the medullary region, you'll be having the cords and the sinuses. We will discuss that here. You can also see this hilar region from where the efferent lymphatic vessel will come out. The efferent lymphatic vessel will come out from this. A single efferent lymphatic vessel will come out from this hilar region. Okay. Now as I said, let's get into more detail of it. So first, let us focus on this part, guys. First, we'll be talking about this region where you can see the capsule and you can see the lymphatic nodule in more detail and paracortex. And then we will talk about this part, that is the medullary region here. So there we go. This is the picture which is focused to the lymphatic, the cortex and the paracortex part mainly, although we can see the medulla also here. So let us talk about the features of the histological features of the lymph node, guys. Starting with, obviously, it is having this capsule which is made up of the Dell's irregular connective tissue. And you can see these septations which are coming out of the capsule, which are called as the trabeculae. The trabeculae or the septations. And as we just discussed, deep to this capsule and then also deep to this trabeculae, we have this subcapsular sinus, and that will continue deep to this trabeculae also as a subtrabecular or paratrabecular sinus. I'm just trying to label them so they are at least readable when you see them in the soft copy. So one thing is that we do have cortex and medulla in case of the lymph node, and that is not the case in spleen. When we'll go to the slide of this spleen, there will be no cortex and medulla, so it's all mixed up there. So we do have a cortex and medulla, and what you can see here, that lymphatic nodule are essentially present in the cortex part here. So these are here the lymphatic nodule. So lymphatic nodule, which as I said are present essentially in the cortex region. They are only present in the cortex or the cortex region here. And these lymphatic nodules, they do have these B lymphocytes. They predominantly have these B lymphocytes present in these lymphatic nodule. If you see a lymphatic nodule without a pale stained region in the center, then it is a primary lymphocyte that you can see in there. I'm just writing a primary here. And this one you can see there is a pale stained germinal center in here. You can see this germinal center. That's a secondary lymphatic nodule. That's a secondary lymphatic nodule where you can see the pale stained center. So we have more of a lymphoblast present in the center, and then they mature and they move toward the periphery actually. So the central part is basically pale stained here. And then we said, guys, we have this paracortex region. See, let me tell you what I'm going to do is I'll send you these slides. I'll make sure I'll send you 2 slides, one labeled and one unlabeled, so that whatever I'm writing and I might be hiding few features in this because of all these labeling. So you will be having this unlabeled slide as well. Now look at this. This region here is the paracortex, or the so-called as the deep cortex region. So this is the paracortex. And paracortex region, part of the lymph node, is mainly having the T lymphocytes, guys. This is the one which is having the T lymphocytes. And these T lymphocytes, because of the T lymphocytes present in this region, that is the paracortex region, is also called as a thymic dependent zone as well. That's a question asked once in the exam. The paracortex region, part of the lymph node, is called as a thymic. This is a thymus dependent zone. This here is the thymus dependent zone. We'll go into more enlarged view of this the part. And now look at this whole thing here. This is what you have, where you have these medullary cords and sinuses. And what exactly medullary cords and sinuses are, we will see that. So broadly what I'm saying is that we have this encapsulated slide you're looking at. That is, we have a presence of capsules there. We have a distinct cortex in the medulla. The junction of the cortex and medulla is called as the paracortical region or paracortex, where we have predominantly the T lymphocytes, the thymus dependent zone, and we do have these lymphatic nodules which are arranged or aligned in the cortex part, which may be having a germinal center or may not be having a germinal center, depend upon whether it is exposed to the antigen or not. And then in the middle part, in the medullary region, we got the medullary cords and the sinuses. Okay. Now, if I just focus on one lymphatic nodule, let me take, guys, this portion in more. Let me zoom in this region here so that we can see it more up close. Look at that. Now, can you see that? This clearly here is the capsule part, right? That's a capsule region. You can clearly see that subcapsular, and you can see the trabecular also. I'm just writing T for the trabecular. And can you, I hope you can appreciate that space over there. The subcapsular and the subtrabecular sinus can be seen. Look at that. This obviously is the germinal center. Once again, that is the germinal center. And this whole thing is the lymphatic nodule. That is a lymphatic nodule. And just below that or deep to the lymphatic nodule, that will be the region for the paracortex. So just to show you one more magnified picture of that. And there will be a very major difference between the lymphatic nodule that you will see in the lymph node and in the spleen. In the spleen, there will be the arteriole that you can appreciate there. In this, there is no arteriole present inside here. Okay. Now, if I take your attention to the middle part, that is the medullary part here. Now, look at this picture, guys. That's again, it's a magnified view of that medullary region where we have medullary cords and medullary sinuses. So now these discretely arranged lymphocytes which are present, look at this cluster here, look at this cluster here. Now all these are called as the medullary cords. So these are the medullary cords here, and these medullary cords, they do have B lymphocytes. They do have B lymphocytes. They got the plasma cells. And they obviously also have these macrophages. The B lymphocytes, plasma cells and macrophages. And these are the random clusters of these lymphocytes and plasma cells which are present in the medullary region. That's why the name given to it is a medullary cord. It's like the medullary cord. And what you see in between these medullary cords, we have these endothelial line spaces present, which are called as sinuses. These are the medullary sinuses. Now look at that, guys. Look at this space in there. Look at this space in there. These are called as medullary sinuses. And just to remind you again, we said medullary sinuses are the one which are receiving the lymph from where? From the subcapsular and subtrabecular sinus, right? That was subcapsular and subtrabecular sinus. So that lymph coming from the subcapsular and subtrabecular sinus, it converges into the medullary sinuses, and from the medullary sinuses, it will obviously be going through the efferent lymphatic vessel, that single efferent lymphatic vessel that we have exiting from this, the concave part of the lymph node. So medullary cord and medullary sinuses. Now, let me tell you guys, these medullary sinuses, one important thing that you should know about, that they are traversed by the reticular fibers. We do have a lot of trabecular fibers which are present inside. Reticular fibers, I'm sorry. In thymus, there will be the reticular cells. We have a epithelio-reticular cells over there. We will talk about that. Here we have the reticular fibers, and they are the one which supports these, the B lymphocytes, the plasma cells, and the macrophages. So these medullary region, it is traversed by the reticular fibers. That is traversed by the reticular fiber, and this is the one which is forming the support system here in the parenchyma. So this is the one which supports these B lymphocytes. It supports the plasma cells and even all these macrophages. And this support system will be a bit different in case of thymus, where you will have all those appendages coming out of the epithelio-reticular cells connected to each other. We will see that here. So that is a section of the lymph node. So what we saw till here, we saw that if I just quickly recap this thing, when you look at the convex part of the lymph node, then we have a lot of afferent lymphatic vessels entering inside. The lymph is drained into this subcapsular and subtrabecular region, sinuses. From there, it goes into the medullary sinus, and then from medullary sinus, it's a pathway of lymph we are talking about. It goes from the efferent lymphatic vessels going from the concave, the hilar region of the lymph node. So we have a single vessel present over there. We can divide the slide of the lymph node into the cortex and the medulla. We have a lymphatic nodule present in the cortex, which may be having this slightly stained region in the center as a secondary lymphatic nodule is the feature. And then we have B lymphocytes are the predominant lymphocytes that we have in that. Paracortex region, which is present at the junction of the cortex and medulla, is having the T lymphocyte, that is a thymus dependent zone. And if you move more inside into the medullary region, we have medullary cords, where we have randomly arranged clusters of these B lymphocytes and some plasma cells and macrophages also. And medullary sinuses, which are traversed by the reticular fibers, forming the supporting system in the parenchyma of the lymph node. So these are some important histological features of the lymph node. Well, obviously the differentiation comes when we move on to the next slide. So we got to look at the next one, the features of the next slide, and then we will understand how we're going to differentiate between the lymph node and the thymus and the tonsil and the spleen. So guys, next in the line we have the spleen. This is just a schematic presentation of that. We have open and closed circulation in the spleen and all that. We will come to that part later. The first thing first, guys, the spleen is basically the largest lymphoid organ. It's the largest lymphoid organ, the spleen. And as we know that in fetal life it is hematopoietic. And then after birth, this becomes the graveyard of RBC. This is the graveyard of RBC. And how come it's the graveyard of RBC? What are stave cells? We will all talk about that. So largest lymphoid organ, the spleen. We're talking about the spleen, of course, here. In fetal life, as we said, it is for the formation of the RBCs, and after birth, it is the one which becomes the graveyard of those RBCs. Okay. So let us see the differentiating features and the features of the spleen. So first, let's see in a low magnification, guys. Let me put a slide here, which is a low magnification of this. What is present here, which is common to the lymph node, and what is not here? The first thing is what is not present here. We cannot differentiate the slide of a spleen into cortex and medulla. So guys, first important thing to note here that there is no cortex and medulla. So if there is no cortex and medulla in case of spleen, that means the lymphatic nodule are not confined to any one part. I mean, just like in lymph node, we have the lymphatic nodule confined to the cortical region. Here they are splayed everywhere, and you can see this lymphatic nodule, you can see present in the entire slide, present everywhere. But just like just like lymph node, they also have the capsule. We do have capsule in case of lymph node as well. Anyways, we're talking about all these encapsulated organs, which is again made up of this dense collagen connective tissue only. This dense collagen connective tissue is forming this capsule here. And we do have some smooth muscles also present inside. In certain mammals, the number of smooth muscle is way too much compared to human. We do have some smooth muscles also present inside the capsule, which basically is to pump these the blood outside the limb. So it slightly act as a pulsatile organ only, the spleen, which helps in the repulsion of the blood out of the organ. So that is done by some smooth muscle which are present in the capsule region. Now we do have a capsule and we do have a trabeculae also, guys. Now the thing about the trabeculae or the septation of the spleen, how it is different from the lymph node, that first of all the trabeculae are very short, they are thick, they are robust, and they are branched. The trabeculae, they are thick or robust, you can say. They are thick, robust, and branched. I mean, let me remind you, in the lymphatic nodule we saw it was a capsule like this, and then from the capsule we have these trabeculae coming out, and these are usually a clean trabeculae which are coming out, long trabeculae present over there, and they do not branch. Usually they don't branch, and then obviously dividing that into the cortex and medulla part here. That was the case of what? Lymph node. This is the lymph node we're talking about. But in case of spleen, from the capsule you may see these trabeculae coming out, and they'll be thick and branched and trabeculated like this, and also having these trabecular blood vessels present inside them, which are the branches of the splenic arteries. Trabecular blood vessels, so trabecular arteries will be present, which ultimately will go into the parenchyma part, rest of the parenchyma. So these trabeculae are different from the lymph node. You will not see as clean trabeculae as you saw it in the lymph node. They are short, they're thick, they're branched. In fact, in this section, I can see all these are the pieces of the trabeculae. Look at that. These are the pieces of the trabeculae itself. This also. And we do have blood vessels also present inside, many of them. So no cortex, no medulla, do have a capsule, smooth muscles are present in the capsule there, and we have a thick, robust, and the trabeculated and this branched trabeculae there. Now, let's get more inside. Let's get into the detail of this slide. So if I look into more closer view of this spleen, now what you're looking at here, guys, is that the presence of the red pulp and white pulp, the feature, the one very, very important feature of the slide of the spleen, the presence of red pulp and the white pulp. Now what is this red and the white pulp is? The white here basically is for the WBC only. The white pulp is basically about these lymphatic nodule. Now look at these lymphatic nodules which are present, and as we said, because there is no cortex and medulla, so they are splayed in the parenchyma everywhere. So these are the lymphatic nodule. And how the lymphatic nodule of the spleen is special and can easily be differentiated from the one which are present in the lymph node is by the presence of these splenic arteriole inside. Initially the splenic arteriole was in the center, and then we have a lymphocyte surrounding them. But when there's a formation of the germinal center, you will see this blood vessel is actually shifted toward the side. So although it is eccentrically placed, but we usually call it the central splenic arteriole. When we have like you're looking at here, this is the one. If I take example of this one, this is the one which is having a germinal center. This lymphatic nodule is having a germinal center. So blood vessel is not in the center, it is more toward the periphery, but we still call it the central splenic arteriole, which is actually eccentric in position because of the proliferation, which is actually shifted toward the side. So this here is the splenic arteriole. So presence of an arteriole inside the lymphatic nodule, it is very, very unique to the spleen. You will not see it in the lymphatic nodule of the tonsil. You will not see that in the lymphatic nodule of the lymph node, but you will see it in case of the spleen, presence of splenic arteriole. And these, let's say if this is a splenic arteriole here, it is surrounded with those lymphocytes, and they form a sheath around it, And I hope you must have read about this sheath in path also. That is called as a peri-arterial lymphatic sheath. Pulse, P-A-L-S, pulse. So we have this blood vessel. I'll show it to you in one of the schematic picture also, that we have a blood vessel running through these lymphatic nodules, and they are surrounded by these lymphocytes, and they form a sheath around them, which makes it, the artery looks very prominent. The walls of the blood vessel look very prominent, and one of the reason is also because we have this peri-arterial lymphatic sheath which is present around it here. So guys, no cortex, no medulla there, but we have the red pulp and the white pulp. And what is white pulp? We said white pulp is nothing, it's just the lymphatic nodule only. So when you say the word white pulp, we are actually talking about the lymphatic nodule inside the spleen, which is also having a splenic arteriole present. And in the one which is a secondary lymphatic nodule, it will be seen more toward the periphery, eccentrically placed central splenic arteriole, surrounded by the periarterial lymphatic sheath. Then what else you will see here, that in between the lymphatic nodule, if you look at this slide guys, this region is showing a very strong red tinge here, and that's why the name given to it is the red pulp. We call it the red pulp. Red pulp, well, what exactly is the concept of this red pulp and white pulp? We will understand that in the splenic circulation, which is next. There is a point when there's some splenic arterioles, they also splay their blood into the parenchyma of the spleen, and that is the concept of the open circulation in the spleen. So this is because of the cells of the blood stream, especially the RBCs which are present in this parenchymal region, which is giving it this a strong red appearance in a fresh section, and that's why the name given to it is a red pulp, because we have the RBCs present over there, and we have other blood, circulatory blood component as well. So the presence of the RBCs and presence of red pulp is basically an indication of the open circulation. Presence of an arteriole inside the lymphatic nodule suggests you that we do have a closed circulation. Obviously we have blood vessel there, and presence of RBCs in between these lymphatic nodule, in between these white pulp region, is an indication of an open circulation, which we will talk about in a while. Let me just enlarge it even further guys. If I enlarge it even further and look more closely, and look at this here. So I'm just showing you one picture here, in which you can see a lymphatic nodule. Obviously that here is a lymphatic nodule here, right? That is the splenic arteriole. I'm just writing SA splenic arteriole. This here is a lymphatic nodule. Okay. Now basically the purpose to show this picture is to out of this white pulp. Now out of the white pulp, now we have this red pulp. In this red pulp, what you will see, we again have these the splenic cords and splenic sinusoids are present guys. If you again see, we have the cluster of the randomly arranged these lymphocytes present in there. We do have amount of lymphocytes and plasma cells present in this region also. So these are called as the splenic cords of Billroth. You must have heard of this name, splenic cord of Billroth. This also is one of the question asked in the AIIMS. The cords of Billroth are present in what? They are present in the spleen only. And this splenic cord of Billroth, what they have, what exactly they are made up of? Actually, they are made up of the loose connective tissue. It's not dense, it's present in the capsule. We do have a loose connective tissue present here. We do have a loose connective tissue present here with obviously the plasma cells. We do have plasma cells, and obviously we have the macrophages and the lymphocytes. And what's the function of those macrophages? We'll also discuss that in the upcoming part. And lymphocytes. So that's a splenic cord of Billroth. Okay. So this is all we are talking about the red pulp region guys. This is all in the red pulp actually. And then we have all these spaces. Now look at these spaces in between guys. All these spaces we have here, endothelial line spaces. These are called as splenic sinusoids. These are called as the splenic sinusoids. Now what's this splenic sinusoids here? We have these endothelial cells, and these specialized endothelial cells here in this region are called as the stave cells. We got the endothelial cells present here, which are, because of the specific arrangement, we call them the stave cells. like a stave of a wood, guys. When you look at the stave cells, these endothelial cells, the basement membrane of these endothelial cells is actually disrupted. So we have like openings present in between. Let us say I'm looking at these sinusoids here. So we have these endothelial cells present here, and you can see there are gaps in between. We do have these gaps in between. These are the endothelial cells, and these gaps in between are the one which are actually allowing the passage of the RBC to come in and go out here. And the size of these openings in between is around 2 to 3 micrometer. So that's the size of of these openings, this discontinuation basement membrane that is present in between. The concept here is that RBC, if RBC is within its life cycle, then RBC is flexible, and that can actually go through these spaces and can enter into the sinusoids here. So RBC it can actually go through these and can enter into the splenic sinusoids. But after the completion, after the 120 days life cycle of the RBC, there is a less flexibility in the RBC after that. So if I say after 120 days, so we have this flexibility going down, and therefore these RBC, they get entangled here. They are not able to mold their shape, and they cannot enter inside the sinusoids. And that is a signal, that is an indication for the destruction of the RBC. If they're not able to go inside the sinusoid, they will not escape the spleen, and they will stay inside, and that's where the macrophage cells which are present in the cords of Billroth will come into the picture and will eat up these cells here. That's how the destruction of the RBC is done in the region of this, the red pulp region here. So what I'm saying is that we have these, the slits in between, which are 2 to 3 micrometer in size, and that is allowing the RBCs to escape inside. If it is the young RBC, older RBCs which cannot flex, the less flexibility is there, cannot escape through this route, and that's why they stay inside this red pulp region. And we already said we have macrophages present in the Billroth region, and those macrophages will eat up these RBCs here. Okay. Now let me take a schematic picture here to again make you understand about this closed and the open circulation in the spleen. So guys, if I may look at this picture here, I'll post this picture in your group. Okay, let me go in a sequence, and I want you to just follow where I'm taking you in this. Like starting with the trabecular arteries, we said we have a trabeculae, and those trabecules are having these trabecular arteries. These trabecular arteries, they become the central artery of the lymphatic nodule. You can see all these lymphocytes present over there. So we have a lymphatic nodule or the splenic nodule there. Look at this periarterial lymphatic sheath, which is the lymphocytes present around the blood vessel. But you can see few blood vessels, they escape the lymphatic nodule and they continue into this sinuses region, the medullary, splenic sinuses we have, and then ultimately finally into the trabecular vein. So basically starting with the artery and then going into the venule region and finally into the vein, that is basically the closed circulation. That's closed circulation theory. What is the open circulation theory here? We can see some blood vessel escaping these lymphatic nodule, and these arteries are called as the penicillar arteries, guys. Do remember this name? They might ask you this. These are the penicillar arterioles which escape from this lymphatic nodule. You can see those macrophages which are also present there, and they are the one which will splay their blood into the parenchyma of the spleen. Now, we saw that red pulp because of this RBCs present over there. Look at all these RBCs in this region here, guys. And that gives the appearance, the red over there, because of these RBCs which are coming out of the blood vessel into the open circulation here. These are the same endothelial cells, the stave cells. Can you see that? The stave cells. And we have this horizontally running reticulin fibers which are actually holding all these stave cells together. And we do have a slit in between, and you can see the RBCs are escaping through this slit and going inside, and ultimately, finally going into the systemic circulation only. But as we said, if the RBC is not able to bend through and not able to escape through these slits which are present in the basement membrane of these endothelial cells or the stave cells, then they are the one which are acted upon by these macrophages. Look at these macrophages which you can see here, and will be eaten up here. So this is a picture which is showing you the both type of circulation present in the spleen. We have You can see the closed circulation, and we do have an open circulation, which is formed by these peninsular arterioles, which are splaying the blood into parenchyma, and then ultimately from the cords of Billroth, they are escaping into the sinuses region, the medullary, not medullary, sorry, there's no medulla there, the splenic sinusoids. So guys, moving on to the next one. So we talked about the lymphatic lymph node, and we talked about the spleen. If I just very quickly compare the two, so both the things, what both are having, they both are having a capsule, common thing. They both have trabeculae, but the difference, capsule, the lymph node is having the capsule which is relatively thin, long and unbranched, whereas in spleen we have a short trabeculated and robust, the trabeculae is present. We do have subcapsular and subtrabecular sinus in the lymph node. Nothing of that sort in case of spleen. There is cortex and medulla in case of lymph node. No cortex and medulla in case of spleen. And then we can see we have all these the lymphatic nodules present everywhere, everywhere in this spleen, and we do have an arteriole present, which was not there in case of obviously lymph node, and that's a splenic arteriole there. And we do have in the parenchyma the signs of the RBCs present over there, which is indicating of an open circulation. That's why I divide the section into the white and the red pulp region. Chali, moving on to the next one. The next slide here is the slide of the thymus. So look at this picture. This is a slide of thymus here. So guys, thymus out of all these is one central lymphoid organ. It's a central lymphoid organ. And one important thing about the thymus is the dual origin. See, there's a special name given to this because of this. There is a dual origin of the thymus. Now, what is the dual origin I'm talking about here? The epithelio-reticular cells. The epithelio-reticular cells, they are the one which are derived from the endoderm of third pouch. Well, I'm saying pouch, then I don't have to say the endoderm. Pouches are endodermal only. So these epithelio-reticular cells are derived from the endoderm of the third pouch, whereas the lymphocytes will be derived from the mesoderm. That will be derived from the mesoderm of the pharyngeal arches only. So because of this dual origin, there is a name given to this thymus is also called as the lymphoepithelial organ. This is called as a lymphoepithelial organ. This is also called as a lymphoepithelial organ here. And another feature, before we go into more detailed here, another feature of the slide of the thymus, you will see that we do not have, there is only efferent and there is no afferent lymphatic vessel here. We have only efferent and no afferent lymphatic vessel in case of thymus. Some basic overall features here, that we have central lymphoid, this is central lymphoid organ. We have a dual origin when the third endodermal pouch is giving rise to the epithelio-reticular cells, whereas lymphocytes are coming from the mesoderm. It's a lymphoepithelial organ therefore, and only efferent and no afferent lymph vessels are seen. Like in case of lymph node, we have afferent as well as efferent both. In fact, we have more of an afferent and only one efferent. Here only we have efferent lymph vessel. Just like lymph node and spleen, this is also having a capsule and trabeculae. But see, what is to be noted here, guys, although it is a low magnification, but you can still see there is a capsule there, right? And this capsule is giving off these trabeculae. Now look at all these trabeculae which are going in. And what these trabeculae are doing, they're dividing this thymus into the incomplete lobules. The lobules are there inside, but the lobules are still incomplete because the trabeculae entering inside are not going to the core. So they are dividing them into incomplete lobules. Look at this one here, this is one here, there's another one here. So these are all incomplete lobule, the incomplete lobule. We do have a cortex and medulla, but what you see here, it's not a common cortex and medulla. We have a if you look at all these lymphatic, thymic lobules you're looking at, They do have a cortex. Look at this. This portion here is a cortex here, guys. This is a cortex, the one which I'm marking at here. That again is a cortex. That's a cortex here. And this region is the medulla, and medulla is the one which is shared by the multiple cortices. So many incomplete lymphatic lobules, they're sharing a common medulla. This lightly stained region in the center is the medulla. So we have, when you look at a part of this one section, and we have incomplete lobules having separate cortex, but when you look at their medulla, they are all kind of having a confluence in there. So we have a common medulla in okay. The thing is, let me just take this one part here in more detail here. Let me just take one enlarged view. There you can see it here. So this slightly strange region here, that's the one which I'm highlighting here, that is the medulla. And you can see this medulla here, even this medulla here, it is shared by the multiple lobules. Look at this, this entire thing. That's a medullary part. So slide of thymus, so obviously in the cortex part we have the T lymphocytes. And for a strange reason, out of the majority of the T lymphocytes which are formed in the thymus, most of them they die in the thymus itself, and very few escape. They go out of this escape route of the thymus, but very, very few are the one which are escaping here. Majority of the T lymphocytes, they die in the thymus itself. There is no lymphatic nodule. The one differentiating feature you'll see here, that there is no, there is no lymphatic nodule. We do have a clusters of the the lymphocytes present, but they are arranged and packed into the cortical region. But as such, we don't have any lymphatic nodule like in case of spleen and the lymph node. Now, if I take you more close to this part, into the medullary part, guys, let's see one picture in which you can see more close into the medullary region. So what you'll see, that in the medullary region, I hope you can appreciate these cells. Now look at the one which I'm marking. Look at this one here. I'm pointing out these. Look at this one. These cells are called as the epithelio-reticular cells. These are epithelio-reticular cells. And these epithelio-reticular cells, what is the feature that you see? I hope you can appreciate in that slide. These are having these pale staining oval nuclei. It can be appreciated here. You can see the pale staining oval nuclei there, and we have a eosinophilic cytoplasm there. Pale staining oval nuclei and the eosinophilic cytoplasm. See, the thing about this epithelio-reticular cell is, now let us say if this is one epithelio-reticular cell I'm looking at, and these having these appendages which is attached to the neighboring reticuloepithelial cells like this. And these appendages are joined to each other by the junctional complex by the desmosome. So these epithelio-reticular cells, they are connected by the desmosome, and that's how they are actually providing the support framework for these thymocytes, or you can say lymphocytes. So reticulin here is not by the reticular fibers, which were in other case of, like in case of the lymph node and the spleen, there was a reticular fibers here. Here we have epithelio-reticular cells, and the appendages of these cells are connected to each other by the desmosomes, and that is how they're forming the entire network in there, which is providing the network for this thymocyte. So the structural framework of the spleen is by these ER cells only, by these epithelio-reticular cells. And then the most important feature in the medullary region of the thymus is the presence of this thymic corpuscle or the Hessel's corpuscle. Thymic or the Hessel's corpuscle. Number of Hessel's corpuscle, obviously they increase with age. What exactly are these? These are lamellated acidophilic bodies. If you look at this one, it looks like lamellated. So you'll see many lamina present around it. These are lamellated eosinophilic bodies. In the center, you have the hyaline matrix or hyaline mass is present. So we have a central hyaline mass, which are having this central hyaline matrix or central hyaline mass, something like this, and which is surrounded by these dying reticuloepithelial cells. Which is surrounded by this dying reticuloepithelial cells. So we have this central hyaline mass here, and we have these dying epithelio-reticular cells here. So it's very prominent. With the age, the number of Hassel's corpuscle will increase, and that becomes one of the main identifying feature of the section of the slide of the thymus here. So what you saw in the thymus, guys, which makes it different from the lymph node and the spleen, that number one, again, we have a capsule there, we do have a trabecular here, and trabecular is dividing the cortex in such a part that we have an incomplete lobules which are formed, having an individual cortex, separate cortex are there, but we have a common medulla which is shared in between. No lymphatic nodule, so we have lymphocytes, the T lymphocytes, which are actually present in the periphery, in the cortex part. The central portion, which is having less number of these lymphocytes, so it is more pale stained, and we have more of a epithelial reticular cells present here, which are itself pale staining cells, and they form the main meshwork, the main network, the main structural framework for the thymus, connected to each other by the desmosome and supporting these and all thymocytes. In the medullary region, you'll also see these eosinophilic bodies present in between, which are called as Hassel's or thymic corpuscle, one of the main identifying feature, having this central hyaline mass and which is surrounded by these dying reticuloepithelial cells. And very lastly, I'm gonna go to this one last slide, which is very easy to differentiate because it's just about now the comparison, guys. We already know about lymphatic nodule. So what you see in this slide, we have lymphatic nodule. Now, obviously, this is a picture slide which is having all these lymphatic nodules are present in there. So one thing, we have presence of lymphatic nodule. Capsule is also present, but it is not to be seen here because the slide is quite wide, and to show the epithelium, I have to hide that capsule part. The second important thing, lymphatic nodule present again in the cortex part. So we do have a cortex in this region, cortex and medulla here. And more importantly, what you see, that the oral surface of this slide is covered with this stratified squamous epithelium. And you can see this stratified squamous epithelium, it is actually indipping inside this oral surface of this palatine tonsil. These are called as a tonsillar crypt, the tonsillar crypt. So presence of the lymphatic nodule, obviously without those arterioles, because if there was an arteriole present in the lymphatic nodule, then you might confuse it with the spleen. Obviously there is no arteriole in there. So we have like lymphatic nodule, just like the lymph node we have in there. Stratified squamous epithelium, which is facing toward the oral surface, and the presence of the tonsillar crypt. Like the three things are good enough to identify it is a slide of a palatine tonsil. It is a slide of the palatine tonsil. So usually people don't confuse this slide actually. The only confusion might come with the lymph node. So just make sure that you look at the stratified squamous epithelium, and I'm kind of sure about it. If they give this slide in the exam, they will make sure that the crypt or the stratified squamous epithelium or both will be shown in such a way that you can easily differentiate it. Because if once I hide the stratified epithelium and the tonsillar crypt, then it becomes a bit difficult to differentiate between the lymph node and this one. Although there are other features also, like medullary cords and sinus, which is not in there. If you look at the entire section of the palatine tonsil, more into the basal surface, more toward the lateral side, you might see some skeletal muscle also. I'm sure you all know that the bed of palatine tonsil is formed by the superior constrictor muscle, and superior constrictor is a skeletal muscle. So when you see the oral surface, you will see stratified squamous epithelium, and when you see more toward the lateral side, you may notice some skeletal muscle fiber over there, and those will be the fiber of the skeletal muscle of the superior constrictor fiber could be seen there. So guys, this is about the features of the lymphoid system slide. This is like good enough for us to differentiate between these slides in the exam. Need not go into the extreme detail of this. There is a lot of detail regarding this, regarding the entire mechanism which takes place in the lymphatic nodule, how the helper T cells are present there, how their antigen presenting cells are present there, dendritic cells are how they are present in there, and what they are doing. So we don't have to go into that detail. We basically need to look into mainly the differentiating feature portion of the lymphatic nodule. So that is it for the day. I still took almost an hour to discuss these 4 slides. So leave your questions and comments and feedbacks, everything in the comment and in the comment box. I'll answer them once I'm done with this, after closing this video. And also, yes, this video will be uploaded in the eGurukul app also. This will be uploaded in the eGurukul app. It will be done. So guys, thank you. Give me the feedback for this class, so that we can actually do any changes if needed for the upcoming session. The next Monday we have planned for the osteology session. I'll be discussing the osteology of the upper limb in 2 parts. On the Monday we'll be discussing the clavicle, scapula, humerus, and the major attachments and some clinical implication of that part as well. So till then, it's goodbye from my side. Take care.